In the state of New York, we remain the only state in the country that doesn't formally recognize CRNA practice in law. Instead, scope of practice is defined through regulation, and physician supervision is required, regardless of clinical necessity. Today, we investigate two questions. Why does this arrangement persist? And whose interests does it actually serve? This is that story. So I think a good place to start is with the problem itself. Right now, CRNA practice in New York isn't defined in law at all. There isn't a statute that says what a CRNA is permitted to do, independently, not independently. CMS has allowed states to opt out of the federal physician supervision requirement since November of 2001, but New York has never used that option. National research on reduced scope of practice restrictions gives us a real evidence base for what those changes, what changes happen when the requirement is lifted. And there's a current bill, S357, sponsored by Senator Cooney, and that would finally codify a CRNA scope of practice. But even this bill would retain a physician collaboration requirement rather than full independent authority. We'll come back to that. So moving beyond the question of statutory recognition, there's a second related piece of the regulatory picture, and that's whether a state requires physician supervision at all. Back in November of 2001, CMS created a mechanism for states to opt out of the federal physician supervision requirement entirely. The governor simply has to attest that opting out is consistent with state law and in the interest of the state's citizens. So now, over 25 years later, New York has still never exercised that option. So what we're looking at on this map is where that choice has actually been made. Vermont just joined this group as of, I believe, a week ago. So these states in blue have opted out and they allow CRNAs to practice independently. New York is not one of them. This is a mechanism that is entirely within our governor's authority to invoke. This isn't just a matter of like a legal formality either. Tarazi and colleagues, in a 2005 study using nearly 9 million anesthesia procedures performed nationally, found that reduced practice restrictions during the pandemic were associated with measurable differences in both service utilization and patient safety outcomes across states. And they were favorable towards CRNA independence. So the map isn't just like a patchwork of like different rules for like different folks. It's showing us like different levels of access and real consequences for the people who can get anesthesia and how quickly they can get it. So the specific nursing framework that I'm looking at is Chin and Kramer's emancipatory knowing. And I can kind of start with like where it came from. In 1978, Barbara Carper identified 4 fundamental patterns of knowing that made up nursing knowledge, and those were empirics, which is the science of nursing; aesthetics, the art and skilled practice of nursing; personal knowing, which is a nurse's authentic self-awareness and relationship with the patient; and ethics, so like the moral component of practice. Peggy Chin and Mayona Kramer later added a 5th pattern, which is emancipatory knowing. And they positioned it as kind of central to the other 4, working as best as they could. So empirics, aesthetics, personal knowing, and ethics are all meant to be kind of built on top of a critical justice-oriented lens. So emancipatory knowing in action was defined by Chin and Kramer as the ability to recognize social and political problems of injustice or inequity and to realize that things could be different, and then to identify and participate in social and political change to improve people's lives. So the key here is that you're participating. It isn't just we're reflective or describing, a pattern of knowing. It is really oriented towards praxis, action, doing. Their model describes a process where a nurse critically examines the current status quo and then imagines more than just circumstances and then makes moves towards action. And that can include things like action plans, critical analyses, even they said manifestos. I love that. And they're specifically about things that like count as successful change. So these have to be sustainable and evaluated, contributing to actual equity, And it has to like demystify or expose the processes that produced the injustice in the first place. So that is kind of a place where I wove in my next idea, which is Paul Farmer's framework. I wanted to pause a moment and kind of plug emancipatory knowing as like a nursing concept into emancipatory knowing as a larger concept in dialogue with other specialties. So, Chin can trace it back to two philosophers in particular in her work, and that's, Jürgen Habermas and Paulo Freire. So Habermas described three fundamental human interests that shape everyday life, and those were technical interest, things like controlling and predicting our environment; practical interest, things like how we get along with and understand each other; and emancipatory interest, which is a human capacity to recognize that something in the social order is wrong or it's unjust, and then that impulse where you try and make it right. The third interest is sort of the philosophical seed of where Chin and Kramer build on their theories of emancipatory knowing. And then Freire's contribution comes from kind of a different place. He developed his theory of human liberation while teaching literacy to sugarcane workers in Brazil at a time when literacy was actually a prerequisite for voting. So what Freire gives us is this vocabulary of how domination actually functions day to day, how a dominant group's version of reality becomes so normalized that everyone, including the people who are disadvantaged by it, start to experience it simply as the way things are. And he called that a kind of hegemony. So put together, it's kind of like the core premise underneath everything that I think I'm going to try and argue here, which is that the injustice isn't natural, it isn't fixed, it's a construct that people make through systems, languages, and norms, which means that it can be dismantled by people. And I think that makes it possible to ask about CRNA regulation in New York. Is that, is this just an unfortunate policy gap? Probably not. And then whose reality is this arrangement actually serving? And why has it come to feel like completely unchangeable? So this is kind of how Chin and Kramer's nursing emancipatory knowing framework kind of dialogue with Farmer's structural violence frameworks. And I like the idea of kind of using them together. I think they have a little more bite that way. So Chin and Kramer say that like nurses should recognize injustice and act on it. But I felt like towards the end, their model doesn't quite give like a fully worked out theory of like how the structural injustice gets produced and sustained over time. And I think Farmer does a nice job. Paul Farmer was a physician anthropologist. He developed a concept of structural violence, and that violence that's exerted indirectly and systemically through the way a social order is arranged. That harm happens without any single identifiable actor pulling a trigger. He describes it as structured and structuring, so it constrains both the choices available to people before they ever walk into a clinic. So I think that's kind of like a great historically grounded lens that gives emancipatory knowing sort of a concrete content for this particular problem. In literature thus far, in nursing scholarship, sort of how emancipatory knowing has already been used, I really liked this bridge I found where Burton, Gilpin, and Drow and Moray's 2021 concept analysis. And they used Chin and Kramer's own method for developing conceptual meaning to formally analyze structural violence for nursing science. Meanings, though, like these two frameworks have already been put in conversation with each other in peer review literature, which is the move that I'm hoping to play around with here. There is maybe a gap, which is that emancipatory knowing specifically hasn't been applied to things like advanced practice, scope of practice, and regulatory questions. So kind of looking at how these systems affect further down the line, and if that results in inequities and harm further downstream, whether that is on the provider side, on the patient side. So to kind of apply these ideas to the New York situation, we have no statute defining CRNA scope of practice. CMS has allowed states to opt out of the federal physician supervision requirement since 2001, again, over 25 years ago, and New York has simply just not done it. The legislation to codify scope has been introduced repeatedly under different bill numbers across multiple sessions, and it stalls every time, like the Bills in the playoffs. So, kind of using Farmer's lens, this isn't like a series of isolated clinical or administrative decisions. It's this really structured, reliable pattern. And, it's even worth noting like the legal literature on physician supervision itself treats supervision largely as like a liability and an administrative construct rather than like a pure clinical safety determination. So it's just kind of like an erased or obscured framing that's interesting to look at. So these like emancipatory knowing or structural violence frameworks kind of harp on the point that like the structural violence, like it has to be embodied somewhere. It has to show up as a measurable like differential outcome somewhere, not just as like an abstract where we're like, that's not fair. So Palmer and colleagues in 2025 found that hospitals in states that have opted out of the federal CRNA supervision requirement are, for example, 19% more likely to staff CRNAs without medical direction. Hospitals in areas with low or moderate maternity care access are 14% more likely to rely on that same kind of independent staffing model. In other words, like the opt-out measurably changes how care gets delivered in these areas that really need it the most. Separately, Tarazi and colleagues, using over like 9 million anesthesia procedures in a national claims database, found that during the pandemic, reduced CRNA practice restrictions actually saw a small but statistically significant decrease in anesthesia-related complications compared to states that made no change. So it was safer, question mark. It wasn't less safe. So we have two things now: this hard evidence that regulatory barrier is removable without safety being compromised, and also evidence that removing it can change who gets access to care. So that's kind of what Chin and Kramer mean by demystifying these processes that produce injustice. So what I like is that like Chin and Kramer can kind of give you like the mandate and the argument that like recognizing injustice is part of a nurse's business. Like you can't just be like, oh, that's somebody else's job. Like, nope, like it's part of doing the whole nursing thing. And specifically like an APRN, and that we need to act on these things, not just describe them. And then Farmer kind of gives a mechanism of like historically a grounded account of like how barriers like these get produced, sustained, and disguised as something other than what they are, and how these all come together to like cause harm. So it kind of gets you to move from this like, this is unfair feeling to like a specific evidence-based argument about why the system persists and why that would need to change. So this kind of builds into what I'm thinking about playing around with for my DMP project, trying to build it around like a policy analysis or advocacy document supporting both opt-out from the CMS anesthesia supervision requirement here in New York and real scope of practice recognition, title recognition. So using these kinds of exact mechanisms that CMS put in place 25 years ago. And my thought is that Chin and Kramer's praxis structure of things like critique, action plan, evaluation map really well onto how a project like this could be phased based on some research that I've done. So I think that these studies kind of help to support where that could go rather than just like starting from scratch. So, of course, no framework is going to be without limitations. I think that the strength of pairing these two ideas together is that they're kind of inherently action oriented and gives me kind of this like real historical empirical grounding. one of the limitations is that I'm kind of extending emancipatory knowing into a domain of like regulatory scope of practice policy where it hasn't been super heavily applied before. So I'm kind of working on figuring out some of that translation work. And because farmers' work comes from outside nursing, I have to make sure that it's nicely aligned with the direction that we're going in. So to bring it together, putting Chitten-Kramer's emancipatory knowing together with Farmer's structural violence framework kind of lets me reframe the stagnation around CRNA regulation in New York as like a produced historically embedded inequity with real consequences to patients. So just thinking that like the barrier to anesthesia access in this state is not like a clinical issue, it's like a structural, historical, political, regulatory issue. And we already have this like regulatory mechanism that's sitting there unused that could change it like the flip of a switch. And I like that it's very much oriented towards like action. And I think that's important.